let's go ahead. So it's my pleasure then to introduce Dr. Artin Mahdanian, who is a psychiatrist who trained here at McGill, among other things, and who's been worked in a variety of settings. He'll tell you a little bit about that in the North and internationally, and is now based in part in Washington. And I'll let you say more, but we're delighted to have you back. He has written a very interesting review, which I think I gave you to read, on human rights in psychiatry. But he also is working in what he'll explain in a moment in terms of existential psychiatry, which I think offers us a very different take. I mentioned at the beginning of the course that this year is unusual in that there are a number of topics that we're bringing in that enlarge the whole discussion in global mental health around human rights, around existential psychiatry, to more around geopsychiatry. So I hope ways that move us beyond the sort of just public health question of how do we translate, best available evidence into global interventions, and really encourage us to think more deeply about what it is we're doing and how we can really connect to local knowledges and values. So thanks a lot, Artin.
Okay, thank you so much, Dr. Kirmayer. Bonjour tout le monde. Hello. It's a great pleasure to be here. I'm Artin Mahdanian, as Dr. Kirmayer just kindly introduced. Give me a second. I see my... Okay. Now, I have no disclosures to mention that I do not represent any organizations, but I have the honor of working as independent contractor with multiple places, including a student clinic at McGill University and in Washington, D.C., Teladoc Health. I also work as a locum psychiatrist north of Quebec and in Iqaluit, Qikiqtani General Hospital. So my objective today is to talk about two aspects of psychiatry that relates to some sort of ethical and philosophical aspects. The human rights, we will go through the definition, history, and implications of human rights in psychiatry, and then a little bit on political abuse of psychiatry, and then the existentialism and existential aspect of looking at psychiatry. Towards the end, if you have time, I would like to introduce two new notions that I'm working on to introduce to psychiatry. One of them is right-based existential psychiatry, and the other one is the related psychotherapeutic approach, which I call it dynamic eclectic existential psychopharmacotherapy, or DEEP. And I hope by the end of this session, you are able to get your answer why traditional healers work, because it's not about what they do, it's about the relationship. In my opinion, not 100%, but we will see, and we will look at things. So I'm a firm believer in biopsychosocial spiritual cultural model, and I believe that not only mental illness, mental health conditions, or health conditions in general, but also we are product of biopsychosocial events. So I'm biased by my biopsychosocial background, definitely. So I wanted to talk a little bit about my journey. I did my medical school in Tehran, graduated as a family doctor, practiced in rural areas of Iran, Baluchistan border of Iran and Pakistan, then moved back to Tehran, worked in a minority Armenian clinic, waiting for my immigration visa to Quebec. And as soon as I got my immigration visa, I chose a very interesting position as train physician for 3 months, traveling all over Iran by train, providing healthcare to rural areas that there's no access other than train to those areas. So those 3 months I traveled in Iran. And then I moved to Montreal. I did a master and my psychiatry residency at McGill. And given my international interest, I did a lot of training and internships all over the world, WHO, London, and then I did my fellowship at Johns Hopkins. After graduation, I have been working mostly independently between Washington, D.C. and Montreal and north of Quebec, Nunavut, and I have also done some volunteer work in Kenya. So a little bit of background in pictures, top left, my middle school, top right, working in Baluchistan as a GP, and the bottom left, a trained doctor. That was a great experience, and they don't have it in Iran anymore, but there are areas in Iran that you can only access going by train. and you could practice as a trained doctor, seeing patients on the train and in destination, staying 24, 48 hours, then coming back by train. And after I got my immigrant visa, I had my aunt making this flag of Quebec as my scarf, working in hospital with that proudly that I'm moving to Quebec. And I worked as internationalization advisor of Tehran University Chancellor for a while as well. And this is my current work setting and after work setting. So Iqaluit Nunavut, I was there a couple of months ago, -20 and super beautiful, deprived of a lot of services, north of Quebec and McGill University. Now let's get to business. Human rights. Very simple definition. We all know what's human rights. These are like rights and freedoms that all individuals are entitled to have them, regardless of any label that we can give them: nationality, ethnicity, gender, religion. These are essential. Everybody must have them, and inherent. Nobody gives it to you, nobody takes it from you. Yuval Harari argues in his book Homo Sapiens that we are not born equal, and he might be right because of the genetic backgrounds and the geographical determination of place of birth. But even if we are not born equal, we all have the equal rights, regardless of any other labels, any other differences that we have. We can categorize human rights into two major categories: civil and political rights. Mostly when we talk about human rights and basic human rights violations in different settings, we talk about civil and political rights: right to life, liberty, freedom of speech, security, freedom of religion, and due process. All those are in category of civil and political. And then we have economic, social, cultural rights, which I consider them as a higher level of rights, like right to education, housing, healthcare. And not all states, all jurisdictions agree about these, economic, social, cultural rights to be basic human rights. A little bit about history of human rights. I put it there to brag about the Cyrus Cylinder as an Iranian. That's one of the earliest true kind of human rights charters in the world that talks about freedom of Jews, abolition of slavery, freedom of worship. Everybody's free to worship their gods. And it comes much after Code of Hammurabi. And Code of Hammurabi, if you look at it, you might think that this is a terrible discriminative document, but looking back at the history, that was very advanced back then, that masters could kill a slave without any consequences. Code of Hammurabi added consequences if they kill a slave, but they were still allowed to kill a slave. Middle Ages entitlement time, enlightenment, not entitlement time, we have Magna Carta as one of the first regulations that included human rights in them, and that's limiting the power of king in England and giving some rights to the civil people, to the peasants in the country. Enlightenment thinkers followed on that to add on human rights aspects. And then we fast forward to US Declaration of Independence. United States as the first democracy, well, modern democracy. We know that, there were democracies before in Greece or some other civilizations, but as the first modern democracy, he, in the Declaration of Independence, talked about right to life, liberty, pursuit of happiness. Then it comes the French Declaration of Rights of Citizens and the movements of abolition of slavery in the UK, US, and all around the world. And then again, a little bit fast forward, World War II, severe, I think one of the worst human rights violations in the history of world happened all through during the World War, and probably right after the World War that we haven't heard about. But the countries decided to sit and make a charter about human rights that neither the conquerors nor the losers they can violate human rights of people. And as you can see so far, human rights history, like most other things in life, are evolutionary. You know, I'm by nature an evolutionist, so I believe everything is in the process of getting better and improving. So is the human rights. So UN Declaration of Human Rights included a lot of things in there, but not included some, like, as we said, social cultural rights, like right to work, right to food, right to education, healthcare right, and a controversial right about dignified death that we may talk about it later if we have time. UN Declaration of Human Rights was about human rights of general public people, but it didn't talk at all about people with disabilities, mental health conditions, or physical health conditions. So 2006, 2008, United Nations Commission on Human Rights provided the Convention on the Rights of People with Disabilities. It was ratified in the United Nations, and then the countries followed suit to ratify them in their parliaments or congresses. As of today, I believe, unfortunately, United States has not approved that, and all the other countries, including Canada, who have approved the CRPD, they have not applied the CRPD articles into their mental health acts. Now, CRPD has 50 articles, and one of the major things that CRPD requests is reform of mental health acts to remove any form of coercion or limit any form of coercion and include the human rights of people with disabilities. Some of the articles in the CRPD that are important is the right to accessibility. So it considers health as a human right, and everybody needs to have access to healthcare and mental health care. Equal recognition. People with mental health disabilities or physical disabilities, they should not be deprived of anything because of the disability. Right to liberty and freedom, protecting integrity, and right to employment. And also it includes kind of patient's autonomy and patient's consent in the whole process of treatment. Now, looking at CRPD talks about health in general. It's about people with disabilities that includes mental health. If we look at mental health specifically, we can see that some parts of CRPD apply to mental health. One of the major one is accessibility of treatment. Everybody should have access to mental health care. Even in developed countries and high-income countries like Canada, United States, there are areas that they don't have psychiatrists. For example, Iqaluit, Nunavut, 30,000 people, they have about 2 or 3 psychiatrists that they rotate. One psychiatrist is in-house always there, but the other 2, 3, they go and back. So see 10,000, one psychiatrist per 10,000 population, which is not ideal with high rate of suicide there. The second aspect that applies to mental health is informed consent. It's a very controversial topic. If you put the hat of a human rights activist, any form of coercion, compulsory treatment, or confinement of patients is violation of human rights. If you put the hat of a clinician, it's inevitable sometimes with the resources that we have in the community. So it's an area that the CRPD Commission and governments, they are constantly debating on how to improve the human rights of people in terms of informed consent. But there are areas that we all agree, like dignity, non-discrimination, least restrictive environment, and right to privacy and confidentiality. Now that we know what parts of human rights apply to mental health care, it's easy to understand the violations of human rights. So it's a very basic violation of human rights in mental health is lack of access. So if we accept that health is a human right and mental health is part of health care, so the governments, the states are responsible to provide health to all the citizens of the country. So, but the reality is most countries lack adequate services. This data is from WHO about 5 years ago. Might be things a little bit different now, but about a third of countries don't have any community care facilities in rural areas. Third of countries have no specific budget for mental health. It's a budget for healthcare, but it's not specified which part is for mental health. And about 20% of countries spend less than 1% of their healthcare budget on mental health. But we know that a lot of mental health conditions are among the top on the list of burden of disease for countries. And the number of psychiatrists, as we said, ranges from 10 per 100,000. For example, Kenya, I did a volunteer work there, and there are 15 psychiatrists for the whole population of the country, which is about few million people. And it's not an ideal situation. So WHO recommendation is to transfer mental health care to community level in terms of task sharing with primary care providers and community workers. I guess Brandon Court was supposed to present on that task sharing, but I'm not sure if it happened or not for you guys. So the second area is stigma discrimination. That's mostly what happens in the community level and also in mental health care services and government state level. People with mental health conditions should not be deprived of any civil rights, right to vote, right to marry, right to have children. It might sound a little bit basic, but we know that a lot of people with intellectual disabilities in a lot of countries, they have been deprived from the right to marry, to have children, for the fear of passing the intellectual disability to the next generation, or with the argument that they don't have the capacity to decide on those areas. Right to employment, education, and right to choose where they want to live. Inappropriate detention in prisons, that's still a big problem. In countries, developed countries, high-income countries like United States, it's still a big problem. In countries like Canada, maybe a little bit less. But there are a lot of people with mental health conditions that they are confined in a prison for a crime that happened in the context of their mental illness, their mental health condition, and they need treatment instead of incarceration. So WHO recommends that there should be independent bodies to evaluate people and find people who have mental health conditions and put them into the healthcare system rather than in the judicial system. The other way around also is something, I mean, vice versa also makes sense to consider that people without mental health conditions who committed a crime use mental health excuse in order to evade the consequences of their crime. That's also a type of violation of people's rights, the victim's rights. So it's an area that it's improving in a lot of countries. Violation within psychiatric institutions, it's very apparent and present in some countries that people are deprived from very basic rights. Like I was in a conference and I heard that in Australia still they shackle patients or put them in cage beds when they are agitated or aggressive, and living in filthy conditions, lacking their own clothing, food, heating, proper bedding. But even in high-income countries like Canada, United States, we can see very subtle violation of rights of people. People are admitted in the hospital voluntarily, but right to have their phone or smoking or visitations are used as some sort of bargaining chip that they should follow the rules to gain these rights. But these are rights that are inherent. You cannot use them. We cannot say that, okay, you can go for smoking if you take your medication, or if you do that. That's some sort of hidden coercion that happens even in most advanced countries in terms of human rights. Now, super controversial area, forced admission or treatment. As a clinician, I know that it's inevitable sometimes to use forced admission or treatment for the benefit of the patient or the public that we are responsible to. But the human rights advocates, especially CRPD, advise totally against any form of forced admission or treatment. And they recommend informed consent. And if the patient is not capable to do informed consent, they recommend supported decision making. They advise totally against any use of substitute decision making for patients. So at the end of the day, the patient should, with any kind of mental health condition, they should have the right to autonomy and to decide what they want as treatment and how they want to be treated. So this is Dr. Denius Puras. He was the former special rapporteur to Right to Health, and he worked a lot. He's a psychiatrist based in Lithuania. He worked a lot on human rights violations in mental health setting because he was the only psychiatrist who had the position of a special rapporteur. And this sentence from him is interesting. He says that justification for using coercion is generally based on medical necessity or dangerousness. So we say that for safety of patient or community in terms of suicide or homicide, we confine patients. But these notions, they are very subjective, and no matter how we define them, there's not much support in evidence-based medicine that the coercion or forced treatment, forced admission is actually reducing any of these outcomes, consequences like suicide or homicide. So dangerousness is often based on inappropriate prejudice rather than evidence. And we know by data now that a lot of diagnoses of schizophrenia or confinement in countries like UK, Canada, US happens in marginalized population like Black population, immigrant population. So there is some sort of prejudice in terms of diagnosis and confinement of these people. Now, a little bit on the abuse or misuse of psychiatry. And then I will talk about political abuse of psychiatry. Any use of mental health diagnosis, treatment, confinement, terminology, other than legitimate health reasons for any other purposes, it is considered abuse of psychiatry or misuse of psychiatry. And by this definition, you know that on daily basis, almost all of us, and a lot of people outside, they are misusing or abusing psychiatry. So-and-so is OCD, that's misuse of psychiatry. We are not using it for healthcare reasons. We are just using it to label someone else. Or so-and-so politician had narcissistic personality disorder. We are using it in order to discredit them, not to help them, not for healthcare reasons. So this is also abuse or misuse of psychiatry. So any psychiatric diagnosis, treatment, confinement should only be used for healthcare reasons. We know that the most abuse and misuse of psychiatry by evidence happens in mental health settings. The biases and discriminations we have towards certain diagnoses is somehow considered abuse or misuse if it is not used for the purpose of treatment of those diagnoses. Now, political abuse of diagnosis is something that happens within a government. And when psychiatry, mental health diagnosis becomes a tool, rather a tool for the purpose of the government, for the political purpose, rather than for healthcare reasons. And psychiatry can be abused by politicians or political activists or governments because it has the power of confining people, labeling people, forcing people to treatment, and discrediting people by stigmatization. So we do not hear about political abuse of surgery or political abuse of internal medicine, but political abuse of psychiatry is because psychiatric diagnosis can be used to discredit the dissidents by saying that they are psychotic or depressed, by forcing the opponents into hospitalization and treatments, forcing them to take medications, electroconvulsive therapy, by using psychiatry in coercive interrogation and punishments, techniques like manipulation or some sort of using psychotropic drugs or medication to put patients in a state to be able to interrogate them or to punish them. And it can be used as a way to suppress free speech and expression. Now, examples of political abuse of psychiatry. Historically, psychiatry, mental health has been abused all over the world. So the countries, jurisdictions that I am licensed and I practice, United States, Canada, United Kingdom, thankfully, there is no current political abuse of psychiatry. But if you go back to history, psychiatry has been abused. And that's, again, because of the one aspect of psychiatry that I call it regression to mean. In psychiatry, we look a lot at giving people and prescribing people to live an average life. And if they go above and beyond that, they can be labeled with some sort of diagnosis. And in United States, when slavery was the routine and the law of the country, drapetomania was used as a way of labeling people that they have the delusion of freedom from being a slave. And the same in Canada, United Kingdom. Soviet Union is one of the countries that has the worst track record of political abuse of psychiatry. WPA, World Psychiatric Association, at some point expelled the Soviet Union from WPA because of political abuse of psychiatry. They had included a sluggish schizophrenia and delusion of reformism as psychiatric diagnoses and labeled a lot of dissidents by these diagnoses. East Germany, Romania, South Africa. In the modern world and current world, there are reports of political abuse of psychiatry. China, Russia, Belarus, Turkey, and most recently Iran, there were reports of political abuse of psychiatry for the purpose of goals of the government. One example in Iran that happened recently was in the aftermath of Woman Life Freedom. The government, the judicial system argued that hijab, covering the head scarf for women, is the law of the country. So anybody goes against it is an antisocial. So the court started to mandate people who were were activists against hijab to go through mandatory treatments for antisocial personality disorder. So we published an article, and also Iranian Psychiatric Association published an article against it, and this activism could change the court decisions. But that's one of the examples of using psychiatry for any purposes other than healthcare. Now, the summary I want you to remember from human rights in psychiatry, the main and most important one is respect for autonomy. So in human rights, we believe that people have the capacity to decide, and their autonomy and informed consent should be respected. The other aspects like non-discrimination, limiting coercive measures in psychiatry, dignity, respect, participation, empowerment, person-centered care, and the idea of supported decision-making instead of substitute decision-making, and recovery-oriented approach is another aspect of human rights in psychiatry. So by this, I would like to jump into existentialism in psychiatry. And I'm talking too fast and too much. If anytime you have any question, any comment, feel free to jump in, or I will also try to leave some time at the end for the questions. So existentialism originally started probably with Schopenhauer, who talked about fear of mortality and fear of mortality as the main drive for kind of human existence. He said that human is fearful of extinction, so most of the things they do is because of that fear. We all remember the Maslow pyramid of needs. And if I want to divide the needs in existential perspective, I can say that will to survival by Schopenhauer is the first layer in the pyramid of existence. Then comes the father of existentialism, Kierkegaard, who is the first person who mainly talked about individual choice. And the way he talked about it was, he said that I don't have any proof that God exists or there is God or religion, but I choose to believe in it. Before Kierkegaard, religion and God was an idea that you didn't choose. It was a fact that it's there. But Kierkegaard talked about it as a leap of faith and described a lot of our anxiety and our despair is because of this freedom and responsibility. Then Friedrich Nietzsche, who was a German philosopher and critic of traditional values, religion. He was actually a critic of culture, and he talked a lot about the search for meaning, values, and purpose. A lot of people consider Friedrich Nietzsche as a nihilist, but he was not a nihilist. He was an existentialist. He talked about the notion of amor fati, which is a notion that you love your life and love your fate in a celebratory, engaging, and radical acceptance way. So he believed that there is no meaning in life, but you are the one who is responsible to make living for your own life and make your life meaningful. And he talked about the will to power, that we can consider it as the second layer in the pyramid of existentialism. And that's similar to the notion of will for superiority that Adler talks about, that now that we are okay with our survival, we are not dying, we are not in war, then it comes the second level that now we want to gain power. We want to be superior to other people, and that's the motive to move forward. Then in 20th century, there were a lot of authors and philosophers that talked about existentialism. Jean-Paul Sartre mentioned that we first exist, then we have an essence. Existence precedes essence. So first we exist, then there is a meaning in our life. So we don't have any fate. We don't come on earth with a mission. We are born, then we should find our mission. Simone de Beauvoir about women's liberation, Martin Heidegger talk about authenticity, and Albert Camus talked about absurdity of existence, which is similar to what Friedrich Nietzsche talked about, that life is absurd, doesn't have any meaning, doesn't have any inherent purpose, and we are responsible for finding a purpose. And he talked about because the universe is silent and we are always striving to have meaning in life, there is a will to rebel. And we can consider that will to rebel as the third layer in the pyramid of existence. So now that we survived, we don't have any fear of death, we kind of have some sort of power in life. Now we want to rebel against the establishment existence to go above and beyond our levels. And this longing for meaning reminds me of a cartoon I used to watch when I was a child in Iran, that there were two detectives, and every session the boss used to give them a mission to go and accomplish that mission. And in one of the episodes, the boss told them that your mission is today to find a mission for yourself. So that's exactly what the absurdity of existence means, that you don't have any predefined mission in life. Your mission is to find a mission for yourself. And then one of the important persons in existentialism is Martin Buber. And I think his notion of dialogical existence is what I mentioned can possibly describe why traditional healers' work mentioned. Martin Buber explains that the human relationships can be defined into two different categories: I and it relationship and I and thou relationship. I and it relationship is a transactional relationship that each of us have a role in the relationship. We know the answers to some of the questions. We are providing something, giving something, taking something in that relationship. And you can imagine a lot of doctor-patient relationships is I and it relationship. The doctor knows the answer, the doctor knows the treatment, the patient comes to get the treatment from the doctor. Martin Buber believed that I and it relationship is not helpful for the person. It doesn't help at all because we don't know the answers. And he somehow looked at the philosophy of Kant, that we don't know the nature of the reality, because what we know is the phenomenon, is our interpretation of reality. But what the reality is the noumenon, that we never can know what exactly is the noumenon. So I and it relationship is based on a fallacy that we think that we know the answer. We think that we know the diagnosis, we know the evidence, we know the guidelines, and we provide care for somebody who came to us to get help. But I-thou relationship is a relationship that both people are equal. Both don't know the answer. And the importance is in this relationship, you are interested to know the other person. You are interested to get to know them and be able to help them, but you don't know the answers. You don't know all the answers. And that's actually how existential therapy and a lot of psychotherapies work. We know by evidence that now they say that regardless of the school of psychotherapy to use, therapeutic alliance is the most important factor that predicts the outcome of psychotherapy. And even in antidepressant medication, we know that the type of antidepressant is less important than the therapeutic alliance between the psychiatrist and patient. So it's about the I and thou relationship. There were also people throughout 20th century who didn't recognize themselves as existentialists, but their work were somehow in line with existential approaches and existential therapy. Carl Jung, with confrontation with the shadow, the notion of persona, collective unconsciousness, and the notion of individuation, that a lot of our existential misery or neurosis or mental health symptoms come from when we want to individuate from the prescriptive social norms, religious norms, or the family or cultural norms that we have. Carl Jasper talked about phenomenology. Instead of making diagnosis, just describing what you are seeing, what is happening with the patient. And Franz Kafka, an author that used a lot of alienation, guilt, and powerlessness. Now, existentialism transformed into existential therapy and the use in mental health by Biswanger and Boss, who introduced the idea of analysis of being. And then Rollo May, in the book Existence, he talked about how we can use existential analysis and psychodynamic concepts to help patients and people who are suffering from mental health conditions. Viktor Frankl is the psychiatrist who was in concentration camp, and then he wrote the book The Man's Search for Meaning, in which he introduced the notion of logotherapy. He used a lot of notions from Nietzsche, from Albert Camus, that one of our most strives is to find meaning in life. And we can consider that the layer 4 in the pyramid of existence. So after we are okay with survival, we are okay with the will to power, we have power in our life, and we have rebelled to gain a different aspect of life and different level of power. Now we want a meaning. Why am I here? What's my purpose? I come, I live, I die. What's the meaning? What's the purpose? And Viktor Frankl used that meaning as a way to treat a lot of mental health suffering. And Irving Yalom, our contemporary psychiatrist who introduced the idea of existential therapy as a manualized therapy, talked about 4 givens of existence. And he said that the grappling with the idea of death, freedom, isolation, and meaninglessness are the main reason behind human beings suffering and psychiatric neurotic symptoms. Now, key concepts in existentialism and existential therapy, as we talked, is existential angst and anxiety of being. So when you are aware that you exist, you are a being, you are here, you become anxious about the meaning in life, the uncertainties in life, the unpredictability of life, imperfection of life. Isolation and connectedness. There's always a battle between the two in existentialism. There's a belief that we as human beings, we are social beings. So there's one aspect of us that wants always to be connected with other people. But at the same time, we are individual people that we like our own freedom and individuality. So this battle between the two aspects of isolation and connectedness makes the anxiety and a lot of mental health suffering. Despair when we are confronted with limitations of existence. Existence, as I said, is imperfect, limited, uncertain, unpredictable. So there's a lot of despair. And we die at the end. You come, you try, you strive, you have will to power, will to meaning, you do everything you can, and at the end you die. So the ultimate human fear is death. It's inevitable. And it can be the central meaning for life. So you can see a lot of wars, a lot of religions are based on the life after death, because that's the thing that you don't know, and you can create a lot of meaning in that. Revolt and rebellion and absurdity are other concepts in existentialism. Now, so far, talking about human rights and existentialism, you see there are some aspects that are common in both human rights and existentialism. And as I mentioned before, the main aspect is the aspect of autonomy and the belief in human beings' capacity for self-awareness and growth. So in human rights, we believe in autonomy of patients' right to decide, informed consent. And in existentialism, the therapist, the psychiatrist, the healthcare provider believes in patients' capacity of self-awareness and growth. And Carl Rogers calls it unconditional positive regard. No matter how severe the mental health condition of your patient is, you should have unconditional positive regard. They have the capacity to improve. They have the capacity to be a better version of themselves. Another common notion between human rights and existentialism is freedom and responsibility. So in human rights, we believe that people have the right to choose. We should not confine people for treatment. We should not coerce people to get treatment or confine them to hospital. And in existentialism, there is a belief that people has the freedom to choose and face the consequences. So a lot of times, our coercion, our confinement is to prevent people from consequences. But if they are informed, if they know freedom and responsibility is part of the game, that people are free to choose and face the consequences. And another notion that common between human rights and existentialism is the notion of authenticity, that people have the right to live the life they believe, even when they faced with morality, religion, culture, they have the right to be authentic, to be themselves. There's no prescription of how people can live, what is the best life. And as I said, sometimes I think psychiatry has become the tool for regression to mean. So everybody should live a mean and average life. In human rights and in existentialism, there is a belief that people should be authentic. There is no prescriptive way of living that is risk-free for people. Now, based on these similarities between human rights and existentialism, I introduced the notion of right-based existential psychiatry. So it's an approach that focuses on shared common grounds between existential philosophy and human rights approaches in mental health. It kind of integrates the principles of human rights as a framework, the right to autonomy, right to no discrimination and freedom, and then uses existential philosophy and existential therapy approaches as therapeutic tools. And it's a way to offer a space of respect and upholding rights for the patients, no matter how severe the mental health condition is. You can respect that people have the capacity to improve and have the capacity to change. Right-based existential psychiatry emphasizes on dignity, autonomy, authenticity, capacity, and all the human rights of individuals in order to help patients to grapple with the deeper existential questions and challenges that comes with existence, with being on earth, with all the imperfection and difficulties. And throughout the therapy, it's important to focus and address the notions of isolation, meaning in life, the relationship of a person with their death and mortality, choice and responsibility. How much do they think that people are victimized themselves in life, or they believe that they are responsible for some of the choices and consequences of their choices. And eventually people be able to find their place in the world in terms of their meaning in life. What is right-based existential psychiatry good for? It's good for patients who feel alienated by traditional psychiatric treatment. In traditional psychiatric treatments, a lot of times we focus only on symptoms, diagnosis, rather than the broader human context. In right-based existential psychiatry, the symptoms, the conditions, syndromes, or disorders are mostly seen as the consequence or as the outcome of human facing the limitations of existence. And the biological aspect of mental health is not seen as the major cause or the predisposing or reason behind the mental health conditions, but it is seen as the consequence of this grapple with these notions of existence. So right-based existential psychiatry aims to honor human rights and existential concerns of all individuals, including patients, fostering a therapeutic relationship that is ethically grounded and attuned to deeper dimensions of human experience. It moves beyond just treating symptoms and emphasizes the importance of patients' right to self-determination and their search for meaning. Now, if we accept right-based existential psychiatry as our framework, then we need a therapeutic tool. Carl Jung says, when a doctor tells me that he adheres strictly to this or that method, I have my doubts about his therapeutic effect. I treat every patient as individually as possible because the solution to the problem is always an individual one. So we have evidence-based medicine, which is very good. It's better than practicing without evidence, but there is a big flaw and fallacy in evidence-based medicine, and it's we remove the individuality of people and we look at the population statistics and data. We try medicine A or therapeutic method A to 500 people and therapeutic method B to another 500 people, and we say that 60% of these people responded, 40% of the other group responded. A statistical analysis showed that medication or therapeutic approach A is better than B. But what about those individuals, 40% who didn't respond to therapeutic method B? Or what about those 40% who responded to therapeutic method A, but now we are removing therapeutic method A from any medical practice because we believe that it was not statistically significant. So it's important to bring back individuality into medicine and practice. So dynamic eclectic existential psychopharmacotherapy, or DEEP in short, is an approach that is eclectic, transdiagnostic, and patient-centered. So it's focused on individuality rather than guidelines. It's based on eclecticism. So eclecticism in psychotherapy is a technique that you do not adhere to one method. You use the techniques, approaches, or tools from different methods based on patients, based on individual patients in front of you. It's a way of integrating theories, principles, and it's all based on the unique needs of the patient. So a lot of focus when you use a CBT model or DBT model or anything, these are all prescriptive, manualized methods. It doesn't consider the individuality of your patient. But when you use eclecticism, you consider all these evidence-based methods, but you use the technique that you think is going to best be applied to the case of your patient and the problem of your patient. Integrative eclecticism is a way of manualizing your eclecticism, and DEEP is supposed to be an integrative eclecticism. Why eclecticism is good? As I said, it's patient-focused, patient-centered, flexible, adaptable. It's not a fixed method that you have to follow one school of psychotherapy. It's empirical, pragmatic, and it enhances therapeutic relationship because you are not a blank slate anymore in the therapy session. You are another human being sitting in a session with another human being. When you use eclecticism and in DEEP, you should focus a lot on common elements of psychotherapies. And we know that common elements of psychotherapies are actually the most important predictors of outcome of psychotherapy, regardless of the school of psychotherapy you use. So therapeutic relationship and alliance, the most important factor, even in medication management of the patients. And it's based on mutual trust, respect, collaboration, empathy, warmth, genuineness, and authenticity of the therapies, and the goal consensus between therapist and the patient. Hope and positive expectancy. A lot of times, this is another factor why traditional healers and herbal medicine works better than modern medicine. In modern medicine, we always treat people by data and life expectancy and the evidence that we have. You have 70% chance of living 3 more months, and there's 80% chance of relapse of your symptoms if you stop taking the medication. So we are not used to giving hope and positive expectancy, while traditional healers and a lot of cultural and traditional medicine approaches, they are based on hope and positive expectancy in patients. And then the other common elements is therapist factor. So the flexibility, adaptability of therapies is much more important than the school of therapy that they use. And the patient factors, strengths, resilience, social support, and life circumstances. So psychotherapies, they all have different focuses. For example, the psychoanalysis, the focus is on bringing up insight. CBT is to bringing change. DBT is to increase the tolerance of problems and distress. But there are common focuses among different psychotherapies. So in deep, the endeavor, the struggle is to use these common focuses of psychotherapies. So creating insight, metacognition, psychoeducation, skill training, cultural and contextual sensitivity. So a lot of traditional psychotherapeutic methods are developed in Western world, and they might not be applied the same to the Eastern or some indigenous communities. But if you focus on cultural contextual sensitivity, it can help you in having a better therapeutic relationship with your patient as well. Behavioral activation, meaning making, and clarifying patients' values and goals. So again, focus on the individuality of the patient and what is their goal. You don't have any value or any goals to prescribe for the patient, but you explore with the patient what is their goal, what is their meaning in life. So deep can be considered as an approach that embodies the right-based existential psychiatry framework. It offers a structure to deliver personalized, ethically grounded, right-based, culturally sensitive, and existentially attuned care. The integration, the modules or approaches that I used in DEEP, I used an acronym ABCDEF, and each element is kind of grounded in evidence-based practice, but the unification and combination of these 6 elements is because of a shared commitment to respect patients' narrative, patients' choices, and patients' meaning-making process. So this is an visual infogram of dynamic eclectic psychopharmacotherapy. The first element is acceptance. I will try to finish in a few minutes and then leave some time for questions. So the first element is acceptance. Acceptance is rooted in acceptance and commitment therapy, mindfulness-based therapies. Even CBT uses acceptance therapy a lot. Existential therapy uses acceptance. DBT uses radical acceptance. And it's actually acknowledging internal and external experiences as it is. The notion of amor fati that Friedrich Nietzsche uses, love your fate. If imagine, Nietzsche says that imagine you're supposed to come back, the notion of eternal recurrence, you come back to this life thousands of times, millions of times, and everything, every experiences, every event is going to repeat themselves. The eternal recurrence or pattern repetition that Sigmund Freud talked about. So the first and most important thing is to accept it. You are powerless in front of it. You cannot change the external events. You cannot change your internal feelings or emotions. So accept 99% of whatever is in your life, outside and inside. Then the second module is behavioral change, which stands the B element of deep. And behavioral change, it's modifying the maladaptive behaviors. So easiest things to change are behaviors. But again, in deep, the difference between behavioral activation in CBT and behavioral change in deep is that behavioral change in deep is not prescriptive. You are not prescribing to patient what to change, what to do. You explore with the patient, and the patient is the one who is going to recognize what behavior needs to be changed. The third aspect and element is the C is cognitive restructuring, and it comes from CBT therapy techniques, and it's reframing dysfunctional thoughts. And again, in the deep framework, the therapist, the psychiatrist, is not the one who recognizes the thought distortions. The psychiatrist, the therapist, does Socratic questioning, dialogue in an I-thou level of dialogue with the patient And the patient is the one who will find and recognize the maladaptive and distorted thoughts that hasn't been helpful in their life. And then the next element, the D factor, is dynamic analysis. So Freud and Jung are the father of psychoanalysis. Freud's psychoanalysis is based on psychosexual model. Carl Jung's psychoanalysis, Jungian analysis, is based on collective unconscious and archetypes. So no matter which technique you use or you wanna look at, I believe, and a lot of existential therapists believes, that it might be right, but it's not going to help your patient. You know, the reason the patient is choosing the wrong partner, if it is because they wanna repeat the same experience they had with their father, and they wanna succeed in this type of relationship, it's not going to help them. They are going to repeat the same and same and same if you prescriptively tell them that this is the analysis. So dynamic analysis in deep, it's not used as a way of analyzing the patient. It's used as a way of understanding the patient, and as a way of giving insight to the patient to explore their own unconscious processes. So there's a lot of techniques like mindfulness, meditation that you can use and help, like using mandala of Jungian analysis to help the patient to explore their own unconscious decisions and processes. So you are not the analyst, the patient is the analyst. You are just a fellow journey traveler that are eager to understand the experience of the patient. And then the fifth element or module in deep is existential therapy, which, as we talked, confronting issues of existence. And I have a couple of slides about the different techniques of existential therapy. So originally, when I was talking about deep, I stopped here and I said that, okay, if A, B, C, D, E doesn't work, then you are F. Then one of my friends said that, no, you can use F as pharmacotherapy, you know, then you can include pharmacotherapy in this method of psychotherapy. And so we added focused pharmacotherapy, and it's I think the first type of psychotherapeutic approach that includes pharmacotherapy as one of the modules in the body of the psychotherapy technique. And it's using medication in a targeted way based on evidence-based medicine, not to treat a syndrome, but to address a bigger picture. And again, the decision to choose the medication is not prescriptive based on guidelines, it's conversational with your patient. You are the person who provides the information, provides the guidelines, provide the evidence, and the patient is the one who chooses and decides what they want to do. Now, quickly, a few minutes about existential techniques, because in deep, the most important factor is existential. And as you recognize all other elements, acceptance, behavioral change, dynamic analysis, they all have an existential flavor. And they step a little bit far from the original approach, which is prescriptive, and you know what to do. In deep, you are just somebody who explores and understands. So some of the major techniques in existential therapy, here and now processing. So Irving Yalom says, I never finish a psychotherapy session without talking about what's happening between me and the patient in that session. So a lot of times when you are seeing a patient, they bring things from outside, from their week, last week, what happened with them and their family, their friends, from their childhood experiences, from their trauma. But we rarely talk about what's happening between us. We are two human beings sitting in this room, two feelings, two emotions, and what's happening between us, how our interaction is meaningful between us. Existential confrontation, gently challenging the patient for avoidance of freedom, authenticity, or taking responsibility. A lot of patients prefer to be part of a cult or religion or prescriptive method because they wanna avoid the freedom and authenticity, the freedom and the consequences and responsibilities that come with the freedom. Mortality reflection. Death and mortality is the most avoided notion in everybody's life. No matter you're a psychiatrist, psychologist, mental health professional, philosopher, you never talk about your death. You avoid it until the very last minute. I remember my uncle was dying and he was suffering from a end stage metastatic cancer. And in the last days, he was talking about the hope that he's getting treatment, he's getting better. And he never talked about death. What's the meaning of death for him? And we are all like that. We never talk about death. We avoid it. We are afraid of it. So sometimes it's important to talk about it. Irving Yalom says, draw a diagram about in front of the patient, tell them that this is your birth, this is here, now tell me where is your death? How far ahead is it? What's the meaning of the rest of your life for you? And asking the patient to imagine their grave. What are they going to write on their grave? And what's the meaning of their death for them? So it's mortality reflection. And a lot of other techniques that can be used in different contexts, paradoxical intention, de-reflection. Life review works very much in geriatric population to sit with patient and talk about their life and the meaning they created in life. Values clarification, meaning making, and some psychoeducation, rippling effect, is another notion in philosophy that Irving Yalom introduces in existential psychotherapy. And it means that we all want to change other people in our life. The patient comes and they have a terrible dynamic with their mother. They have a terrible dynamic with their husband. And they wish to change the husband. They wish to change the mother. But the reality is you cannot change anyone else. But if you change yourself, like the ripples in water, your change is going to create a wave that is going to change everybody around you. And in philosophy, Carl Jung believes that when you change yourself, you change the world. So sit in your room, work on yourself, and you change the world around you. Symbolic letter writing, silence and presence. We are a lot of times uncomfortable when there is a silence between us and a patient, but silence is meaningful. Sometimes you sit together for 5 minutes and just think and just reflect. And that can be something that can be done in existential approaches. And a lot of other techniques that I let you read later. I can provide the slides if you want. And when it comes to global mental health, I always say, think global, but act local. Global mental health is not about traveling the world and confining people, prescribing medications. It's about understanding people. So thank you for listening, and I'm happy to hear your comments and reflections, and we can discuss the questions together. I don't have all the answers. I have none of the answers, actually.
Thank you so much, Artin.